Hi everyone, I'm Dr. Irajan Khandelwal and I'm back again. In this module, students, we are going to discuss the pathology questions which were asked in the NEET-PG exam 2024. So finally, students, the NEET-PG exam is over. We all were eagerly waiting for this exam and NEET-PG 2024 is over. As you all know that the paper was asked in two sessions, session 1 and session 2. Most of the students told me that ma'am, session 2 questions were a bit tougher as compared to session 1. And they are actually right. We also observed that session 2 questions were a bit tougher as compared to session 1, right? If you ask me the difficulty level of the paper, students, the paper was of moderate difficulty. We cannot say that this was a very easy and very one-liner kind of a paper. It was more of a conceptual paper. And it was a paper in which if you have not revised your concepts, if you have not revised your subject 3 or 4 times, you would not have been able to solve the paper, right? So it was of moderate difficulty, right? When I come to pathology, there were approximately 40 to 45 pathology questions without overlaps. But if I include the overlaps, there were around 50 questions, which is a whooping number, students. That is why I always say that pathology is a central subject for all the other subjects like medicine or surgery or gynae or orthopedics. You will find pathology everywhere, right? Now, a lot of repeat topics were there. There were no direct repeat questions as such, but as we always say that the topics are usually repeated, right? For example, Hodgkin's lymphoma, asbestosis, iron deficiency anemia. These are very, very high yield topics we have seen time and again. The examiner is asking questions on them, right? So a lot of repeat topics were there. We have observed for the past 2 or 3 years that general pathology is lesser asked and a lot of questions are asked from systemic pathology, right? So the number of questions from general pathology, that is lesser because now the examiner tends to ask more conceptual questions. General pathology is more of mugging up, so they are becoming lesser. But conceptual questions and medicine integrated questions are becoming more and more, right? So that is why I always tell you students that whenever you study pathology, always read it in integration with medicine or with surgery, right? Because a lot of questions were of long stem, were of clinical and were of medicine or surgery integration, right? Very few one-liners were there, right? Then students, another thing which was a highlight of this paper was the number of images. Students told me that ma'am, almost in every question, there was an image attached. So if you know the images nicely, students, especially of pathology, you will have an edge over other students who don't know the images because it will help you in saving time as well. So I am again saying that please revise your images nicely, right? So without wasting any more time, let us now start with the questions. First of all, I'm going to do the questions which were asked in session 1, right? So let us do the questions. The first question is, which of the following is most common mutation associated with the microscopic image of thyroid shown, right? Very easy question, students. And this is one of the most popular topics which is asked every year in the exam. The topic is papillary carcinoma of thyroid. Now, students, the image which was shown, that was of a orphan ani nuclei. Can you people appreciate that these are the cells which are arranged in papillae, right? And when you look at these nuclei, don't you think that these nuclei look empty, right? That is why these are called as the orphan ani nuclei. Now, where do you see orphan ani nuclei? I see orphan ani nuclei in papillary carcinoma of thyroid. So, it is actually a two-step question. First, I have made a diagnosis. What is the diagnosis? The diagnosis is papillary cancer of thyroid. Why? Because I am seeing orphan ani nuclei in this. Now they have asked that what is the most common mutation in this? What is the most common mutation, students? Remember, I told you in that table, the mutation which is seen in papillary carcinoma of thyroid is BRAF V600E. Therefore, the answer in this question is BRAF V600E. This was a easy question, students. The image of papillary cancer, very important, very frequently asked both in INI-CET, NEET, right? And the mutation also we commonly know, right? Where do you see RET mutation? Remember I told you, RET on chromosome number 10, it leads to medullary carcinoma of thyroid. So, if the image was of a medullary carcinoma of thyroid, if the image showed a lot of amyloid, the diagnosis would have been medullary cancer, and then the answer would have been RET mutation, right? What is the other thing which where RET is seen? It is MEN2 syndrome. MEN2 syndrome, correct? Right, then KRAS students, RAS is the most common oncogene mutated in human malignancy, and KRAS is seen in carcinoma of colon, carcinoma of pancreas. In these conditions, we see KRAS. Understood, students? Okay. Now, this thyroid malignancy is one of the favorite topics for examiner. So, let us quickly revise this table of various thyroid malignancy, which I have told you in the classes, right? So, we have 4 types of thyroid cancer: papillary, follicular, medullary, and anaplastic. Now, if the examiner asks you which is the most common thyroid malignancy, the answer is papillary. Which is the least common thyroid malignancy? The answer is anaplastic. Fortunately, the most common one has the best prognosis. So, if the examiner asks you which one has the best prognosis, answer is papillary. Which one has the worst prognosis? The answer is anaplastic, right? Now, very commonly asked question in NEET exam is, what are the risk factors? If I ask you, what is the risk factor for papillary cancer? Ionizing radiation, thyroglossal cyst, Hashimoto's thyroiditis. These are the risk factors for papillary cancer. And what is the risk factor for follicular carcinoma, students? Long-standing goiter or iodine deficiency. Again, this is an MCQ, correct? Now, all the thyroid cancers, they arise from follicular cells, except for medullary cancer, students, which arise from parafollicular cells of thyroid, right? Then, what type of thyroid malignancy metastasizes by lymphatic route? If that is the question, then the answer is going to be papillary cancer. Remember, I always tell you, students, in a young patient with cervical lymph node enlargement, and if there is thyroid enlargement as well, you always think about one differential diagnosis, that is papillary cancer thyroid, right? Which type of thyroid cancer metastasizes by hematogenous route? That means bone metastasis is very common. Then the answer is going to be follicular cancer of thyroid. Done? Then, students, we come to the mutations. That is also very important, and that is the thing which is asked in our question. Papillary cancer associated with BRAF mutation commonly, follicular associated with KRAS, medullary associated with RET, and anaplastic associated with P53. Correct? If I ask you about the histopathology, what will papillary cancer show? It is called as papillary cancer. Why? Because what we see are cells which are arranged in papilla, right? So, one thing which we see is cells arranged in papillae. Then, the second important highlight of papillary cancer is the optically cleared nuclei. In this image, can you people see that a lot of these nuclei are clear? There is nothing inside. They have been compared to the eye of little orphan Annie, which is a cartoon character, correct? This image was given in the MCQ exam in NEET, right? Then, students, another important thing which we see is coffee bean nuclei. A lot of nuclei, when I see, they will have a longitudinal groove. They look like coffee beans. That is why they are called as coffee bean nuclei, right? Again, orphanania nuclei. Then we have coffee bean nuclei. You can see beautiful coffee beans here, right? Then here, can you appreciate there is an inclusion inside the nuclear, right? So, another thing which we see are nuclear pseudo inclusions, correct? And lastly, students, one thing which we see is the presence of some MOMA bodies. So, another MCQ which is popular is some MOMA bodies are seen in The answer is going to be papillary carcinoma of thyroid. Understood? The 5 microscopic features of papillary cancer thyroid. Why am I repeating? Because one of the most important topics for MCQ exams asked in FMGE, NEET and ionized CET. What are the 5 microscopic features? Papillae, orphanania nuclei, nuclear pseudo-inclusions, some bodies and coffee bean nuclei, right? Then students, if I ask you, what do you see in follicular carcinoma of thyroid? Follicular carcinoma of thyroid, of course, will show a lot of follicles. So you will see cells arranged in follicles. And in addition to that, students, you see 2 important things, vascular and capsular invasion. That means the malignant cells are invading the thyroid capsule and the thyroid blood vessels. So you will see capsular and vascular invasion, right? One question which was asked in NEET-PG exam last year was, which type of thyroid malignancy cannot be diagnosed by FNAC? Fine needle aspiration cytology is not useful. The answer is going to be follicular carcinoma of thyroid. Why? Because on FNAC, you don't take out the blood vessel and you don't take out the capsule. That is why we have to do the histopathology of the lesion. Understood? What do you see on medullary cancer, students? The highlight is amyloid, right? What do you see? Pinkish material will be seen on the slide. The highlight of medullary cancer on histopathology is amyloid. If I ask you what kind of amyloid is seen, students, it is called a cal. What do you mean by cal? Cal means calcitonin. That is why, students, the tumor marker for medullary cancer is calcitonin. Understood? Easy? Okay, let's move forward to the next question. A patient with vomiting, diarrhea associated with skin eruptions. Similar episodes have been seen in the past. After switching to gluten-free diet, his symptoms have resolved. What is the enzyme defect? Again, students, it is a 2-step question. First, make the diagnosis with the clinical history. What do you think? Now, if you revise your subject nicely, you read this line, switching to gluten-free diet, the patient is symptom-free. What will you think of? I will think of that my patient has got celiac disease. Remember, students, I told you, in a patient of celiac disease, the patient cannot have gluten in the diet. Celiac disease again is a very, very popular and high yield topic. I have been telling you that because the number of cases of celiac disease and gluten sensitivity are increasing in India also now, that is why this is a very, very important potential topic, right? So whenever the patient has gluten in the diet, the patient will have diarrhea, the patient will have vomiting, and this disorder is also at increased risk of skin lesions like dermatitis herpetiformis. That is why they have said that the patient has got skin eruptions, right? So with this history, I have come to the diagnosis that my patient have got celiac disease. Now, interestingly, they gave a biopsy of this patient also, intestinal biopsy. What do you see in this biopsy? Now, if you know the images properly, right, you will be able to solve this question very, very quickly. In this biopsy, can you people appreciate that these villi, they are blunted? There is a shortening of these villi, right? Also, can you people appreciate that there is a hyperplasia of some of these crypts, right? So, I definitely come to a diagnosis that my patient has got celiac disease. Now, they have asked what is the enzyme defect. Some students told me that, ma'am, they asked what is the antibody. Which antibody is seen, students? Remember, I told you 3 antibodies which are seen in celiac disease. Anti-gliadin antibody, anti-endomysial antibody, and anti-tissue transglutaminase antibody, anti-TTG, right? So, what will be the answer in this question? Anti-tissue transglutaminase antibody. This is going to be the answer in this question. Very easy. Where do you see ANCA antibody, anti-neutrophilic cytoplasmic antibody? Remember, students, in vasculitis, I told you, ANCA is of 2 kinds, C ANCA and P ANCA. C ANCA is seen in World Cup. C for C ANCA, Cup for C ANCA, and W, World for Wegener's granulomatosis. So C ANCA is usually seen in Wegener's granulomatosis and P ANCA is seen in two disorder students, microscopic polyangiitis and Churg-Strauss syndrome. Remember? So ANCA of course is not seen in celiac disease. ASCA, what is ASCA? Anti-Saccharomyces cerevisiae antibody. Where did we read about it in GIT? ASCA is usually seen in Crohn's disease, right? So it is usually seen in Crohn's disease. So this is not the answer. This is not the answer. Last is anti-parietal antibody. Where do you see parietal antibody? I see parietal antibody in pernicious anemia. Pernicious anemia, correct? So in celiac disease, we see anti-TTG antibody. That is why this is the answer. This was also a fairly easy question, students. But what my point is that you needed a lot of revisions and a lot of concepts to solve all such questions, right? Now let us quickly revise celiac disease in one slide. A patient of celiac disease cannot have gluten in their diet. Now my question to all of you is that what food products have gluten? My patient cannot have brow. B for barley, R for rye, O for oats and W for wheat. My patient cannot have brow, but my patient can have rice. The patient can have maize, right? What is the site for biopsy you will take? We will take a duodenal biopsy, duodenal, right? What are the antibodies? I've already told you. What will you see on histopathology? On histopathology, three things are seen, students. We have already discussed villous atrophy or blunting of villi. Normally, when I see the villi in the intestine, they are like this, right? In this image, can you people see there is a shortening of these villi? Right, so this is called villous atrophy. Can you people appreciate there is a hyperplasia of these crypts, right? So this is crypt hyperplasia. And the third thing which we see is increased IELs. What are IELs, students? Intraepithelial lymphocytes that we can only see on high power, right? So increased IELs. These are the three microscopic features which are seen, right? And for the students, we calculate a score which is called as the Marsh score. That is a histopathological score which a pathologist gives for celiac disease. Understood? So two very important topics have been discussed. Papillary cancer of thyroid, celiac disease. Both of them were anticipated topics and important topics, right? Let's move to the next MCQ. A patient of COPD presented with ARDS symptoms. What is the role of IL-8 in inflammation, right? This was more of a concept-based question where you have to put your logic. IL-8, interleukin-8. Where did we read about IL-8 in inflammation? Remember, students, I told you that IL-8 is a chemotactic factor. It helps in chemotaxis. What are chemotactic factors, students? LIC. L for LTB4, I for interleukin 8 and C for C5a. Remember? So that means this IL-8 is a chemotactic factor. Now what is chemotaxis? What happens in chemotaxis? There is a recruitment of neutrophils. Neutrophils are moving from the center of the blood vessel to the periphery, to the site of inflammation. There is a recruitment of neutrophils. IL-8 is helping with that. That is why the answer is in this question is recruitment of neutrophils. Understood? Another concept-based question which the examiner asked. Very good question, right? Let's move to the next one. A 12-year-old child with cervical lymphadenopathy, surface antigen positivity, CD10 positive, CD19, 20 positive, 3 negative. Some students said that, ma'am, CD5 and 15 more CD markers were given, right? Now, this is a bit of a controversial question, students, because there were two set of students who told me different stories. One set of students said that, ma'am, the image which was given was of DLBCL. Another set said that, ma'am, the image which was given was of Burkitt's lymphoma, right? Now, whatever image was given, that is going to be the answer, right? The patient cannot have mantle cell lymphoma because the markers are not matching with that, right? Now, the options in which students were confused were DLBCL and Burkitt's lymphoma. Both of them can have surface antigen positivity, CD19-20 positivity, but the important thing which I feel you have to notice in this question is the age of the patient. My patient is a 12-year-old child. Which type of lymphoma is much more common in kids? Burkitt's lymphoma. So most likely students, if there was starry sky appearance or cytoplasmic vacuolation, the answer will be Burkitt's lymphoma, right? Because I'm saying because of the age of the child, right? Had it been an elderly patient and if there were large cells which were shown, the answer would have been DLBCL. Understood? Okay. Let's move to the next one. A 55-year-old chronic smoker presents with weight loss, hemoptysis, and TTF1 positivity. What is the possible diagnosis? Now again a repeat topic, students. Remember last year in NEET exam 2023, there were 3 questions which were asked from lung cancer. Lung cancer, very, very high yield topic which is asked. I always tell the students. And even last year, students, in the same session, there were 2 or 3 questions from lung cancer. And the question which they asked last year also was, TTF1 positive lung cancer is. So, which is the cancer which shows TTF1 positivity? The answer is adenocancer. That is why the answer here is adenocarcinoma of the lung is TTF1 positive, right? How do you see the image? What is the role of image in this? Can you people appreciate that we have glands here, right? Adeno means gland. So, you can see a lot of these gland formation which is there, right? And when I see any immunohistochemical marker positivity, it will show a brown color. Can you see all these cells are brown colored? That means this marker is positive, right? What is the answer? Adenocancer. If I ask you, what is the marker for squamous cell carcinoma of lung? The answer is going to be cytokeratin P63, right? What is the marker for small cell cancer of lung? If you remember, I told you it has neuroendocrine origin. That is why small cell lung cancer is positive for 3 markers: neuron specific enolase, chromogranin, and synaptophysin. Understood? So this was a very important, very direct and high yield question which was asked. Again, a very commonly asked topic, repeat topic which was there, right? Now, I always tell you about this table, students. Again, this is a very, very important and high yield table. Revise this table before all your MCQ exam, students, whether it is INI-CT, NEET-PG or FMG. You have to revise this table. 4 types of lung malignancies which are important are SCC, adeno, small cell and large cell. All the lung cancers are much more common in males, right? Except adenocarcinoma, which is usually seen in females. Understood? Most of them are centrally located, except adeno, which is usually peripherally located. If the examiner asks me a question, which type of lung cancer has the strongest association with cigarette smoking? The answer is going to be small cell lung cancer, right? And which is not associated with cigarette smoking commonly, the answer is going to be adenocarcinoma. Sometimes in a clinical question, students, the clue for your diagnosis that this is going to be a SCC or adenocarcinoma can also be the paraneoplastic syndromes which are associated. SCC is associated usually with hypercalcemia. So if my patient has hypercalcemia, you start thinking about SCC. Adenocarcinoma, the paraneoplastic syndrome is migratory thrombophlebitis. In small cell cancer, the patient can have Cushing syndrome, can be associated with hypertrophic pulmonary osteoarthropathy or Cushing syndrome. Understood? Okay. When I asked you about the pathogenesis or the molecular defects, SCC is associated with P53 defect, Adeno is associated with KRAS, EGFR or ALK gene mutation. What is associated with small cell lung cancer? LMYC. Remember students, I told you MYC, another important oncogene which is there. It is of three kinds, LMYC, NMYC and CMYC. CMYC associated with Burkitt lymphoma, very important MCQ. L for LMYC, L for lung cancer. Which type of lung cancer? Small cell lung cancer. N for NMYC, N for neuroblastoma. So it is more common in that, right? When I tell you about histopathology, squamous cell cancer, keratin pearls, desmosomes, adenocarcinoma, we have already seen, glands lined by malignant cells, small cell cancer, small cells with salt and pepper chromatin, nuclear molding and azoparty effect, and large cell cancer shows large pleomorphic cells. Another very important thing is the markers which are frequently asked these days. SCC, CK, P63, P40, adeno is TTF1 and napsin A. Very, very frequently asked questions. Understood? Next question. A pedigree chart was given in which females were carriers and males were affected, right? Now again, interesting question, students. Till last year, the examiner used to give you a pedigree and asked you what is the mode of inheritance. This time, the examiner became much more smarter. What did he do? He did not just ask you the mode of inheritance. He asked you that which of the following disorders will follow this mode of inheritance. So again, a two-step question. First, you have to tell me the mode of inheritance and then you have to mark that particular disorder which follows that particular mode of inheritance, right? So, this is the kind of pedigree which was given. In this pedigree, I can observe that males were commonly affected and females were carriers. Now, what is the pedigree which is seen? What is the mode of inheritance which is there when males are commonly affected? It is usually X-linked. And if females are carriers and carrier state is seen, what kind of a mode of inheritance is there? The answer is X-linked recessive. So, what is the mode of inheritance in this pedigree? It is X-linked recessive, right? Now, this is X-linked recessive. You have to point out and mark that particular disorder which is X-linked recessive in this. Wiskott-Aldrich syndrome, Prader-Willi syndrome, Wilson's disease and achondroplasia. Come on, tell me what is the answer? So, what is the answer, students? Very good. The answer is going to be Wiskott-Aldrich syndrome. Remember, students, I told you the examples of X-linked recessive disorders are very, very important. And the mnemonic is, Lady Harding College girls don't care about foolish word. LHMC, Lady Harding College girls, they don't care about foolish words. L for Lesch-Nyhan syndrome, H for hemophilia and Hunter syndrome, C for color blindness, G for G6PD deficiency, D for DMD, Duchenne muscular dystrophy, C for chronic granulomatous disease and color blindness, A for A-gamma globulinemia, F for Fabry's and Fragile X, and W for Wiskott-Aldrich syndrome. Both the A-gamma globulинemias, Bruton's A-gamma globulinemia and Wiskott-Aldrich syndrome, they have X-linked recessive mode of inheritance. So the answer is going to be X-linked recessive. Now see the other options. Prader-Willi syndrome. Prader-Willi syndrome, does it follow Mendelian modes? No. Prader-Willi syndrome is an example of genomic imprinting or silencing. No mode of inheritance. Wilson's disease, in which there is excessive copper accumulation, is an autosomal recessive disorder. All the enzyme deficiencies usually are autosomal recessive. Achondroplasia, students, it is a autosomal dominant disorder. Remember the mnemonic for autosomal dominant disorder? He has a very dominant father. A for achondroplasia. Remember I told you? That is why that is an autosomal dominant disorder. So the answer here is Wiskott-Aldrich syndrome. Again a concept based but easy question, right? Let's move to the next one. A 2-year-old child is brought to the OPD with the mother complaining that the child is not feeding well and has bilious vomiting. The child is diagnosed with congenital megacolon and aganglionic segment of the colon. Now here the examiner has reduced your problem of diagnosing. The examiner has directly said that the patient or the child has got congenital megacolon and aganglionic segment. Can you tell me a congenital disorder in which there is an absence of ganglion cells? We have done it in surgery. We have done it in pediatrics. What is the answer, students? The answer is Hirschsprung disease. It is called as congenital megacolon or aganglionosis because the patient has got absence of ganglion cells in the intestine. When the examiner has written these lines, I am 100% sure that the diagnosis is Hirschsprung disease. This diagnosis most of the students could make, but where the students got confused is the histopathology, right? The examiner was very smart. What he did, he wanted to test your basic concepts, right? He gave you a histopathological image of the intestine. What are the layers of the intestine, students? Mucosa, submucosa, muscularis propria, adventitia. And we have the plexuses of ganglion cells which are there, right? Now they asked, which of the following layers are affected in this condition? The layers in which the ganglion cells are present will be affected. Layer 1 and layer 2. Are the ganglion cells present in layer 1 and layer 2? No. They are not present in the mucosa, right? Never in the mucosa. So that's not the answer. Layer 2 and layer 3. Are the ganglion cells present here in the mucosa and the submucosa? Muscularis propria. Yes, they are present there. So what is going to be the answer? The answer is going to be layer 2 and 3. Layer 3 and 4? No. And layer 1 and 4? Of course not. So what is the answer? Layer 2 and layer 3. Because the ganglion plexuses are present in these layers. Understood? Very, very good question asked by the examiner, right? Let's move to the next one. Identify the disease with the chromosomal abnormality. I have not shown the chromosomal abnormality which was given. A lot of students told me that, ma'am, the examiner was very smart. He made an image that this was chromosome 15 and this was paternal chromosome 15 and a part of this paternal chromosome 15 was deleted. This is the kind of image which was shown by the examiner. Now, if there is a deletion of paternal chromosome 15, what will be the diagnosis? Come on. Again, not a direct question, but an image-based question. Have you people seen that in all the questions they have asked the images, right? Very, very important. What will be the answer, students? Remember, I told you, P for paternal, P for Prader. If there is a deletion of paternal chromosome 15, the answer is going to be Prader-Willi syndrome. So that is going to be the answer. If it would have been maternal, if I would have been maternal deletion, then the answer would have been Angelman syndrome. Karyotyping syndrome, what happens, students? Deletion from chromosome number 5. So, if there was a deletion from chromosome number 5, the answer would have been Karyotyping syndrome. So, here the answer is going to be Prader-Willi syndrome. Remember the differences which I tell you about Prader-Willi syndrome and Angelman syndrome? They are both the examples of genomic imprinting. What do I mean by imprinting, students? Imprinting means silencing. So, normally all of us know that we have a maternal allele and we have a paternal allele. If there is a silencing of one allele, the other becomes active. Normally, both the alleles are not active. One allele is active, one allele is inactive, right? And that inactivated allele is basically silenced or imprinted. Now, if there is one allele which is imprinted and the other allele that gets deleted, it will lead to some disorders, right? So, P for Prader, P for paternal. If my patient has got paternal deletion, it will lead to Prader-Willi. If my patient has got maternal deletion, it will lead to Angelman syndrome, right? And the other will be disomied, right? So, in paternal deletion, there will be maternal disomy, and in maternal deletion, there will be paternal disomy. The future question can also be the genes which are associated. Prader-Willi is associated with SNORP gene. Prader-Willi starts with P and SNORP ending with P. So, SNORP gene. Angelman associated with UBE3A gene. Angel is starting with A, and UBE3A, it is also ending with A. These are the genes associated that can be a future question. Understood, students? Again, this is a very, very important and high yield topic which is asked in the exam. Next, a COPD patient with a history of smoking presents with some respiratory symptoms. Chest radiograph showed a pan-acinar emphysema. I feel this is one of the easier questions which was asked, that my patient has got pan-acinar emphysema. Which enzyme deficiency is associated with this condition? Remember, I told you smoking is associated with centriacinar emphysema. Pan-acinar emphysema is associated with alpha-1 antitrypsin deficiency. So what is the enzyme deficiency, students? Alpha-1 antitrypsin. This is going to be the answer. Understood? Fairly easy question, students. Again, integration of medicine and pathology. Remember the various types of emphysema which we have? We have centriacinar, in which the central acini is affected, the distal acini is spared. It is usually smoking associated and usually affects the upper lobes. Then we have a pan-acinar emphysema. As you people can see, the entire acinus is dilated. It is associated with alpha-1 antitrypsin deficiency, a very, very important point, and affects usually the lower lobes of the lung. If I ask you, what are the two organs which are affected in alpha-1 antitrypsin deficiency? You have lung, in which there is pan-acinar emphysema. We have liver, in which there can be liver failure and there can be cirrhosis, right? Understood? Very, very important MCQ and easy one. Next question. A smoker with hoarseness and cough. Direct laryngoscopy was done, which showed the following lesion. So students said that then, ma'am, there was some whitish lesion which was shown on laryngoscopy. What is the stain used for diagnosis? So this was a slightly tricky question, right? The patient has got hoarseness, cough. The patient is a smoker, right? Some whitish area. That whitish area could have been some dysplasia, or it could have been some cancer, especially because you have been given the history of a smoker with hoarseness and cough, right? Now, out of all these stains which are given, we have to point out a stain which is used for dysplasia or cancer, right? Now, if I were a student in your place, I would have solved this question. How? By exclusion. Now, look at the stains which are there. One is Congo red stain. Where do you use Congo red, students? Remember, I told you it is the best stain for amyloid. Congo red under polarized microscopy shows apple green birefringence. What shows? Amyloid, right? So that cannot be the answer. HNE is a common stain which we use in histopathology. That cannot be used to see cancer only. Supravital stains are used to see reticulocytes. They are used to see reticulocytes. That means they are the stains which we use in hematology, not in histopathology. That cannot be the answer. So, what answer do I come to, students? Silver nitrate. So, students, this is another approach which we have to follow whenever we are solving MCQ exams, that we have to exclude the options. The answer here is silver nitrate stain. Silver nitrate stain, students, can be used to see dysplasias and malignancies. That is why that is the answer. Understood? Let's move to the next one. Which of the following is not true about von Willebrand's disease? Again, students, the topic is very important, commonly asked, but not the question. This question is not commonly asked, but we have all done it in our videos. What are the types of von Willebrand's disease? You people tell me. Remember, I told you there are two types of defects which are seen. We have quantitative defects and we have qualitative defects. Qualitative defects. Quantitative, that means there is decreased quantity of von Willebrand factor, and qualitative means there is poor quality. Quantitative defects are of two kinds. We have type 1 von Willebrand's disease and type 3. Remember, everything has been done in class. and qualitative is of one type, that is type 2. Type 1 is more common, type 3 is least common. Type 1 has the best prognosis out of these, type 3 has the worst prognosis out of these. Why? Because in type 1 there is mild deficiency of von Willebrand factor, and here we have severe deficiency of von Willebrand factor. Remember all this, right? Now let us see the options which are there. Von Willebrand type 1 is the most severe disease in children. Is it the most severe? No. So this option is incorrect. And what is asked in the question? Which option is not true? That means this can be the answer. This is not true at all. Von Willebrand type 2 is associated with moderate bleeding tendency. Absolutely correct. Von Willebrand type 3 is the most severe disease in children. Absolutely correct. I have already told you. Von Willebrand type 3 has severely low levels of von Willebrand factor. Absolutely correct. So what is the answer? First option, students. That was the answer. Very good question. You could only do this question if you have revised your subject. Right? Next question. A 34-year-old female presented with low hemoglobin, platelet count of 25,000 per millimeter cube. So hemoglobin is low. Platelet count is very low. What is the normal platelet count? 1.5 to 4 lakhs. Increased PT and increased APTT. They had given you the peripheral smear. Which of the following fusion gene is affected? Again, a very good question, students. When I see this peripheral smear, can you see all these cells which are there? Don't you think they look like blast? And in this blast, I can see something which looks like a rod. So these are OR rods. So students told me that, ma'am, a few blasts showed the presence of OR rods. If you see OR rods, students, what you will think of? I will think of the diagnosis as AMLM3, that is acute promyelocytic leukemia. Even the clinical profile is given, that is matching with this: low hemoglobin, low platelet count. Remember, I told you there is bicytopenia or pancytopenia. And why is there increased PT and APTT? Because my patient is landing up with disseminated intravascular coagulation. Remember, I told you this MCQ, that a patient of acute promyelocytic leukemia is at increased risk of developing DIC. It is commonly seen, right? So what is the translocation which you see in AMLM3? The answer is going to be PML-RARA, promyelocytic leukemia, retinoic acid receptor alpha gene. And what is the translocation which we see? T15:17 and PML-RARA. We have done this. Again, a two-step question. First, make a clinical diagnosis and then come to a question. These are all USMLE type questions, students, which were asked in NEET-PG this time. A lot of students had a problem of time management. That is why I'm telling you, you will have an edge if you do the images very nicely, right? BCR-ABL, students, is usually seen in CML, where there is T9:22 translocation. So here the answer was PML-RARA. What is the treatment for AMLM3? That is another MCQ which was asked in NEET-PG last year. Treatment: all trans retinoic acid, that is ATRA, or the other is arsenic trioxide. Understood? What type of AML shows OR rods? What type of AML, students? Maximum OR rods, AMLM3. And a bunch of OR rods is also called as a fagot cell. So what type? AMLM3. Understood? And which type of AML has the best prognosis? Again, the answer is going to be AMLM3. Just to show you a picture, students, this is a kind of picture. In this blast, inside, can you people appreciate this rod-like structure? This is a OR rod which is there. And when there is a bunch of OR rods which is seen, it is called as a fagot cell. Understood? Very important image. Please keep it in your mind. Done? Okay. Next MCQ. Again, a question from leukemia, students. A patient presented with abdominal pain, hepatosplenomegaly, and white blood cell count more than 50,000 per cubic millimeter. When my patient has got hepatosplenomegaly and a very high TLC, what am I going to think of? I am going to think about chronic myeloid leukemia or CML. Which gene is involved in CML? Remember, I told you 95% people of CML usually shows T9:22 translocation, right? So the answer is going to be T9:22 BCR-ABL, right? What is the treatment for CML students? Because there is BCR-ABL and there is a constitutive activation of tyrosine kinase, that is why for treatment we give tyrosine kinase inhibitors like imatinib mesylate, right? Understood, students? So that is why here the diagnosis is CML and the answer is going to be T9:22. Understood? Next, few things about CML students, because this is a very important topic in high yield, usually asked in the exams commonly. Once there was a question, which of the following is not a diagnostic criteria for CML in the accelerated phase, right? Very important. Blast 10 to 19% of the blood or bone marrow. Peripheral blood basophils more than 20%. Persistent thrombocytopenia, which is unrelated to therapy, or thrombocytosis unresponsive to therapy, increasing spleen size, and cytogenetic evidence of clonal evolution, that is T9:22, right? Then another image which is very important is, students, the fish analysis. So in future, the examiner can ask you give you the image of the fish analysis. Here I have told you that red is ABL and green is BCR, right? That is chromosome number 22. Now, if my patient has got CML, there is 9:22 translocation. If the 9 and 22 are translocating or fusing, what will happen? It will show something like this. So this is what we call as BCR-ABL gene fusion. If such kind of fish is seen, I will make a diagnosis that my patient has got CML. Understood? Okay. Let's move to the next question. A short girl with primary amenorrhea not attain puberty. Now, as a clinician, you see a small girl has primary amenorrhea. The patient has got short stature and not attained puberty till now. Identify the chromosomal defect. What will you think of, students? I will think of Turner syndrome, right? When you see a karyogram, can you people appreciate that there is one X chromosome which is missing, right? What is the diagnosis I will come to? The diagnosis is Turner syndrome, and that is the answer. Fairly easy question, students, and one of the favorite topics again for the examiner, that is karyogram and karyotyping, right? This is the karyogram which we see in Turner syndrome. You are seeing loss of one X chromosome. XO genotype, that is 45 chromosomes, is what we see commonly. Understood? What is a karyogram? Let us quickly revise. Arrangement of chromosomes in decreasing order of length, followed by sex chromosomes at the end, right? Now, this karyogram can be used for the diagnosis of chromosomal disorders. For example, if my patient has got Down syndrome, there will be 3 chromosomes here, right, at chromosome number 21. If my patient has got Klinefelter syndrome, there will be X, X and Y. If something like this is there, my diagnosis will be Klinefelter syndrome, right? If I see 3 chromosomes on the 13th position, my diagnosis will be Patau syndrome. If I see 3 chromosomes in the 18th position, my diagnosis will be Edward syndrome, right? So all these chromosomal defects I can diagnose on the basis of this technique called as karyotyping. Now, if patient has got Turner syndrome, students, what do I see? Remember the mnemonic which I told you? Clowns is the mnemonic. That means my patient has got cardiac defects, cystic hygroma is seen, L for lymphedema, O for ovaries. What kind of ovaries do you see? Streaked ovaries or fibrotic ovaries. W for webbing of neck. N for nipples which are widespread, you can see. S for short stature. and short fourth metacarpal. These are the things which we see in a patient of Turner syndrome. Understood? Easy one? Okay, let's move to the next one. A 27-year-old football player collapsed on the field and could not be revived. Autopsy was conducted. On cardiac biopsy, the left ventricle was hypertrophied. I don't have to see the image also. When I read that a football player collapsed and died on the field while playing football, and the cardiac biopsy is showing left ventricular hypertrophy, what is the diagnosis, students? It is hypertrophic cardiomyopathy, HOCM. Remember, students, I told you what is the most common cause of sudden cardiac death in young athletes? If a patient is running, these days we see a lot of people who go to the gym. Sometimes they collapse, right? What happens, students? Why do they collapse? They have usually HOCM, hypertrophic cardiomyopathy, right? When I see this image, in this image, can you people see these are the muscle fibers which are there of the heart, right? And there is a helter-skelter arrangement of these muscle fibers. They are haphazardly arranged, right? So this is what is seen in HOCM, helter-skelter arrangement of these muscle fibers. Again, a very common topic which is asked. Right? So, with the students, let us quickly revise HOCM, hypertrophic cardiomyopathy. Now, what do I see in hypertrophic cardiomyopathy? There is a mutation in sarcolemmal proteins like beta-myosin heavy chain and myosin binding protein C. That's a separate MCQ. What are the mutations which are seen? Mutation of usually the sarcolemmal proteins like beta-myosin heavy chain or myosin binding protein C. Grossly, when you see the heart, you see something which is called as the banana split configuration. Can you see? It looks like a banana split. That is why there is banana split configuration. And it is the most common cause of sudden cardiac death in young athletes. That's an MCQ, right? Again, students, integration between medicine and pathology. When you see the microscope in such a case, what I see is the haphazard arrangement of the muscle fibers, helter-skelter arrangement of the muscle fibers. Done, students? So this was also a fairly easy question. Let's move to the next one. A patient with flank pain, hematuria, histological image was shown. Identify the condition. Chromophobe RCC, clear cell RCC, metastasis. Of course, this is not metastasis. And papillary cell cancer. It is not papillary cell cancer because papillary renal cell cancer will show papillae. Of course, that is finger-like projection. And those papillae are filled with foamy histiocytes. In this image, I am not seeing any papillae. So, this is also not the answer. Now, a lot of students got confused between two options, chromophobe RCC and clear cell RCC. So, they told me that, ma'am, we really got confused, right? Now, in this image which was asked, the examiner clearly did not give you a central cell with perinuclear halo, total clearing. They did not give you these kinds of cells. What they gave is cells with very thick membranes, right? A raisin-like nucleus, right? And some perinuclear clearing which was there. So the diagnosis here was chromophobe RCC and not clear cell cancer. That was the diagnosis. Remember, students, the image which I showed you for chromophobe RCC, this is the kind of image. What we see are cells with well-defined borders. Can you people see? These are the cells. They have very, very well-defined borders. Similarly, in the image which was shown, can you people appreciate the borders are very well-defined, right? And there is a perinuclear halo. The appearance is called as a plant-like appearance. This appearance is called as a plant-like appearance, right? Three extra MCQs which you need to know for chromophobe RCC. One, it arises from the intercalated cells of the collecting duct. Arises from the intercalated cells. Next, what is a special stain used? The special stain is Hale's colloidal iron. Future exam question. And this type of kidney cancer has the best prognosis. The answer is going to be chromophobe RCC. So this time we did not get an image of clear cell RCC. We got the image of chromophobe RCC. In the future exam, students, you might also get a question on maybe the molecular genetics of either chromophobe or papillary or clear cell RCCs, right? So till now, have you people observed that you got a question on thyroid malignancy, very important? You got a question on renal cell cancer, which is very important. You got a question on lung cancer. So malignancies are very, very important. Plus, you got a lot of questions on genetics. For example, pedigree analysis, karyotyping, genomic imprinting. Correct? Let's move to the next one. A thalassaemic patient has received multiple blood transfusions. Aplastic crisis can occur in this patient due to infection from. Very, very easy question. This was one of the only one-liners which we see in the paper. Aplastic crisis, whenever we read about this, which virus is usually associated with aplasia? I told you it is parvovirus B19. So that is the answer. Parvovirus B19 is associated with aplasia in a lot of cases. Done? Next. A child presents to you with bone pain, hepatosplenomegaly, pancytopenia. Trophine aspirate shows the following finding. Which of the following enzyme is deficient? Again, students, this is such a repeat and favorite topic for the examiner. What kind of a cell do you see here? Don't you think it has this crumpled tissue paper appearance of the cytoplasm? See this cell? So this is actually a Gaucher's cell. My diagnosis is Gaucher's disease. And what is the enzyme defect in Gaucher's disease? G for Gaucher's, G for glucocerebrosidase. So what is the answer here? Glucocerebrosidase. Repeat topic, repeat image, repeat question. Done? Then students, the last question from session 1, right? A 3-year-old child brought to the OPD with complaints of persistent delayed development of milestones, macular lesions of the body which are hyperpigmented and more pronounced on exposure to sunlight. What is the error in DNA multiplication? Whether it is base excision repair, nucleotide excision repair, DNA mismatch repair or homologous recombination. If my patient has got skin defect, students, can you people appreciate in this question, you are seeing a lot of skin defects like macula, hyperpigmented lesion, which are more on exposure to sunlight. What is the defect? I will come to a diagnosis that my patient can have xeroderma pigmentosa, and that is due to a nucleotide excision repair defect, NER pathway. That is why this is the answer. Understood, students? So these were the questions which are asked in session 1, right? Let's move to the next, students. That is questions which are asked in session 2. The questions were a shade tougher as compared to session 1, right? The first question. A couple comes for prenatal genetic counseling. They have a family history of hemophilia. They have a male child with hemophilia and normal female child. As it is, students, you all know that hemophilia is an X-linked recessive disorder, right? So males are commonly affected and females are usually carriers. The mother's family has hemophilia and the father's family is normal, right? What are the chances of the offsprings being affected? Now, if my mother's family has hemophilia, which is an X-linked recessive disorder, this was kind of a tough question. Then what will my genetic profile will be? I will carry the hemophilia trait, right? So my thing will be XXH. Father's family is normal, so father is normal, right? So the kids are going to be XXH, XHY, XX, or XY. That means 50% of the girls, if they are born, they will be carriers, right? And 50% of the males are going to be affected, right? So, half of the males affected and half of the females can be carriers. This should be the answer in this question. All males will be affected and all females will be normal? No. All males will be affected and half of the females will be carriers? No, that's not also the case. All of the males and females will be affected? No, that is also not the case. So, what is the answer? You can see half of the females are carriers and half of the males are affected. It is an X-linked recessive disorder also, so that makes sense in this. Understood? Let's move to the next one. A 10-year-old boy comes with fever and pain in his right upper limb. He has expansile lesion in his right radius in the diaphysis. Now, a young patient with fever, lesion in the upper limb, right, a radius, and there is a lesion in the diaphysis. You're talking about a bone tumor in a young patient with fever. Which bone tumor are you going to think of? Students, with just this history only, I am going to think of Ewing sarcoma. Remember I told you, Ewing sarcoma usually affects people less than 20 years of age. Usually affects the diaphysis of long bones. Remember? Right? So I will start thinking that my patient has got Ewing sarcoma. Histopathology is shown below. Now, interestingly, can you people see on histopathology these things? What are these, students? What are these round structures which I see on low power? These are actually the rosettes. Don't you think they look as if tumor cells are surrounding around a central space? So these are what we call as rosette. They look like a rose or a flower, right? Also, Ewing sarcoma is a small round blue cell tumor of childhood. So these are small round blue cells, right? So I come to a diagnosis that my patient has got Ewing sarcoma, seeing the history and looking at the histopathological image. What is the most accurate test among the following? Does Ewing sarcoma show T15:17? No. We just did T15:17 is seen in acute promyelocytic leukemia or AML-M3. Does Ewing show RB gene mutation? No. RB mutation is seen in two disorders, retinoblastoma and osteosarcoma. So that's not also the case. Then T11:22 is definitely the translocation which we see, and EWSR1 fusion gene, ETS fusion gene, that is also the thing which we see. Now the confusion here is, few students said that ma'am both of them were given in the option and they asked the most accurate test. If both were given the option and you have to mark the most accurate test, then the answer is going to be EWSR1. If only T11:22 was there, then this is going to be the answer. Understood, students? You all know that Ewing sarcoma has got T11:22 translocation. On X-ray, it shows onion skin appearance, and on microscopy, it shows small round blue cells with rosettes. So what kind of appearance is seen? This is a small round blue cell tumor of childhood. Understood, students? We see small round blue cells along with these rose-like structures, right? And also the cells are pass positive due to the presence of glycogen. There is glycogen which is surrounding the tumor cells. So all these tumor cells are pass positive. Understood, students? Easy question? Yes, let's move to the next MCQ. 38-year-old women came with complaints of weakness, lethargy and heavy menstrual bleeding. Peripheral blood picture showed small RBCs and pallor. Now, when you have this history, a woman with heavy menstrual bleeding, lethargy, small RBCs and pallor, what do you think of? The small RBCs, matlab they are talking about microcytic hypochromic anemia. I will start thinking that yes, my patient can have iron deficiency anemia, right? Hemoglobin was 7.9. That means the patient hemoglobin is low. MCV is low. MCH is low. Total iron binding capacity is high. And transferrin saturation is also low. What is the diagnosis? You cannot get a more easier question than this. Students, the entire thing which is there, low hemoglobin, microcytic hypochromic anemia, MCV, MCH low, high TIBC, this is all the iron profile and the profile of iron deficiency anemia. That is why the answer here was iron deficiency anemia. You won't believe, students, there were 3 questions in just the session 2 on iron deficiency anemia. And interestingly, all 3 of them were very easy right this time. Now, hemolytic anemia. Can it be hemolytic anemia? No. Why will all these parameters, iron parameters affected in hemolytic anemia? No. Hypoplastic anemia? No. MCV and all is all normal in hypoplastic anemia. Megaloblastic anemia? No. In megaloblastic anemia, MCV is high, not low. That is also not the answer. So, answer here is iron deficiency anemia, right? Another question which was there from this topic was, a 28-year-old woman came with complaints of weakness and fatigue. The peripheral blood picture showed microcytic hypochromic anemia. Remember, I told you in India, the most common cause of microcytic hypochromic anemia is iron deficiency anemia. Serum iron was low. If my patient has low or microcytic hypochromic anemia with serum iron which is low, she had increased RDW. RDW is increased. MCV, MCH were also low. TIBC was high. Again, with this profile, what is the diagnosis I come to? My patient has got iron deficiency anemia. What would her serum transferrin saturation be? What happens to serum transferrin in iron deficiency anemia, students? Of course, it is reduced. So, the answer is it is reduced. Transferrin is basically the transportation form of iron. If there is a deficiency, the transferrin saturation, transferrin is also empty. So, transferrin saturation is also low in iron deficiency anemia, right? Next, another question from the same topic which was asked, which of the following is incorrect about iron metabolism? Iron is transported by binding with apoferritin. No, not at all. Iron is transported by binding with transferrin, right? That is the correct answer. So, this is incorrect. This is the answer. Serum ferritin denotes the iron level in the body. Absolutely correct. Iron is stored in the body in the form of ferritin. Absolutely correct. Free serum iron is toxic to cells. Absolutely correct. So, 3 very easy questions from this very common topic and very important topic, students. That is iron deficiency anemia. Few points about iron deficiency anemia that we need to know. Most common worm causing iron deficiency anemia is hookworm. Site of maximum iron absorption is duodenum. Factors increasing iron absorption are vitamin C, that is ascorbic acid or citric acid. What is the storage form of iron? It is ferritin and hemophilia. What is the transportation form of iron? It is transferrin. What is the master regulator of iron metabolism? It is hepcidin. Quite commonly they ask a question on hepcidin also. What are the clues in the history to suggest that this patient has got iron deficiency anemia? An elderly patient with GI malignancy or a child have eating sand, eating clay, all the other things, that is pica. Plummer-Vinson syndrome, another important MCQ. You can get a clinical question also on this. It's a triad of atrophic glossitis, esophageal webs, and iron deficiency anemia, right? These are the important points which you need to know, right? Next MCQ. Which protein accumulation is seen in Alzheimer's disease? Very easy question. Remember, students, I told you Alzheimer's is a misfolding protein disease, right? So, which protein is accumulated? Amyloid. What kind of amyloid is deposited? I told it to you at 2 points, one in amyloidosis and one in Alzheimer's disease. The answer is beta amyloid. That is deposited in Alzheimer's disease. That's the answer. Very easy one-liner which was asked. Alpha-synuclein is seen in Parkinson's disease. GFAP, glial fibrillary acidic protein, is the immunohistochemical marker for glial tumors. It is used for glial tumors. And albumin is not related to Alzheimer's disease. Done, students? Easy? So, this table of different types of amyloid in different conditions is very, very important. Let us quickly revise. What kind of amyloid is seen in primary amyloidosis? AL. Secondary amyloidosis? AA. Familial Mediterranean fever? AA or apyrin. Familial amyloidotic polyneuropathy? ATTR. TTR means transthyretin. Senile or cardiac amyloidosis, that is aging wala, that is ATTR again. Which type of amyloid is seen in long-term dialysis? Last year NEET question. A beta 2M, that is beta 2 microglobulin. Prion disease, APR. Diabetes mellitus, AIAPP. Medullary carcinoma of thyroid, A cal, cal means calcitonin. And Alzheimer's disease, A beta. All these 9 points are exam MCQs, right? Next, a 45-year-old woman came with complaints of fever, night sweats, generalized itching, and unintentional weight loss of 10% in the last 3 months. On examination, she has enlarged cervical and axillary lymph nodes. The lymph node examination and biopsy showed the following picture. Again, students, if you don't know image of Reed-Sternberg cell, please do not appear for the exam. Every year, FMGE, NEET, INI-CET always give an image of a Reed-Sternberg cell with a beautiful owl's eye. Can you people appreciate this cell? Owl's eye. Now see the history. History of B symptoms like fever, night sweats, itching, right? Weight loss, cervical lymphadenopathy. All these are suggesting a diagnosis of Hodgkin's lymphoma. So this patient has a diagnosis of Hodgkin's lymphoma. What would the likely diagnosis? The diagnosis, of course, is Hodgkin's lymphoma. And what is the treatment for Hodgkin's lymphoma? Remember, I told you we do a ABVD regimen, right? So that is going to be the answer. Is it non-Hodgkin's lymphoma? No. Is it sarcoidosis? No. Why is it not sarcoidosis? If it was sarcoidosis, the lymph node biopsy would have shown you non-caseating granulomas, asteroid bodies, and Schumann bodies. Here, I am clearly seeing a Reed-Sternberg cell. Again, student, image. If you know the image, immediately make a diagnosis and do the question. Easy? So, this time the examiner did not ask you the kind of Hodgkin's lymphoma which is there or what is the marker. The examiner asked you about the treatment, that is ABVD regimen. Understood? Easy, students? Okay. Few things about Hodgkin's lymphoma. This image, please make sure for all exam you know this image. This is a Reed-Sternberg cell, 15 to 45 micron cell, which is binucleate. The appearance is called as a owl's eye appearance. This table of the different types of Hodgkin's lymphoma is extremely important for all MCQ exam students. Please revise this table before the MCQ exams, right? Then students, let us move to the next MCQ. A 45-year-old man came with complaints of tearing chest pain, tachycardia, hypotension with negative trop INT. The wall of the aorta was biopsied and the image is shown below. If I talk about tearing chest pain, what will you think about in medicine? If there is this tearing chest pain, I usually think about aortic dissection, right? And especially when I'm given that the trop I and trop T is negative, that means my patient does not have myocardial infarction. That is not there, right? What is the most likely pathology behind it? And when you see this image, can you people appreciate there is this tear which you see in this wall, right? So this is a case of aortic dissection which is there. Now, they are asking you the pathology behind it. Connective tissue damage of the aortic wall, fibrinoid necrosis and smooth muscle hyperplasia, fat deposition and smooth muscle degeneration, immune complex vasculitis, right? A lot of students told me that, ma'am, this was a tough one. I don't think this is a tough one. One, we have made the diagnosis. I can see a tear. Now see all the options. Can it be connective tissue damage of the aortic wall? It can definitely be. Fibrinoid necrosis and smooth muscle hyperplasia. Will the dissection or tearing due to smooth muscle hyperplasia? No. So that's not the answer. Fat deposition and smooth muscle degeneration. Can you see fat anywhere? I cannot see. Fat is empty spaces. So that's not the case. Immune complex vasculitis. Does it look like vasculitis? No. What is the answer? This is due to connective tissue damage of the aortic wall. Fairly easy one. But you have to correlate again medicine with pathology. Right? Next. A 53-year-old woman came with complaints of fatigue, icterus anasarca, hepatosplenomegaly. She had anemia and neutropenia. Bone marrow examination showed 22% plasma cells and acellular eosinophilic deposit. Now the highlight for me is 22% plasma cells. Whenever my patient has got so many plasma cells, I will think about the diagnosis of multiple myeloma. Now the examiner is saying you also see acellular eosinophilic deposit, some pink material which is deposited in the bone marrow biopsy, right? The bone marrow biopsy is shown below. There was a biopsy which was shown. I don't have the image of that. What is the associated pathology? Do you see coagulative necrosis in case of multiple myeloma? I don't see it. Do you see fibrinoid necrosis in case of multiple myeloma? I do not see it. Do you see amyloidosis in case of multiple myeloma? Yes. Remember, students, I told you, multiple myeloma is commonly associated with amyloidosis. What kind of amyloid is seen, students? AL. And what is that amyloidosis called as? It is called as primary amyloidosis. It is seen in light chain disorders like multiple myeloma. So there is a direct correlation between multiple myeloma and amyloidosis, and amyloid is acellular pink material which you might be seeing. So the answer here is amyloidosis. This was a good question in which you have to integrate a lot of concepts. Understood? Next, a 72-year-old man came with anasarca and icterus. He had hepatosplenomegaly. Kidney function was found to be deranged. So the KFT are abnormal. That is why the patient might be having anasarca. And they are saying the urine gamma globulins were more than 3 gram per deciliter. If the urine gamma globulins were more than 3 gram per deciliter, what you might think of, along with abnormal KFT and all, I might think of that this patient might have multiple myeloma. Electrophoresis of the urine protein is shown below. Which is the most likely diagnosis? One option is monoclonal gammopathy of undifferentiated proteins. No, that's not the answer, because the gamma globulins are more than 3, right? Multiple myeloma IgG. Can you see any band in IgG region? Immunoglobulin G? No. So this is not multiple myeloma IgG. Multiple myeloma IgA. Can you see anything here? No, I cannot see on IgA. Multiple myeloma IgM. Can you see a band here? Yes, I can see. So what is the answer here? The answer here is multiple myeloma immunoglobulin M, right? Understood, students? This is a immunofixation electrophoresis which was given. Very good question, but I could do it by excluding all the other options, right? Next, a 38-year-old woman came with complaints of slowly growing breast lump for the past 6 months. She had history of similar lump for which excision was done and medical mammographic reports are not available. So that means this is a recurrent lump. On examination, the lump was smooth, well-defined, mobile with regular margins. The cytology and biopsy of the same was taken and is shown below. What is the most likely diagnosis? Can it be a fibroadenoma? Yes, because fibroadenoma is also smooth, well-defined, mobile with regular margins. Yes, it can be. Can it be sclerosing adenosis? I don't think so, because in sclerosing adenosis, you don't see sclerosis. You see a lot of sclerosis or pinkish material, which I am not seeing in this biopsy. Can it be Phyllodes tumor? Yes, it can be Phyllodes tumor also. Can it be a leiomyosarcoma? No. Why? Because leiomyosarcoma is a highly malignant sarcoma. Here you have a tumor which is well defined, smooth, regular margins and mobile, right? Leiomyosarcoma is not like that. So, two options I have excluded. Students were confused that whether it is fibroadenoma or it is Phyllodes tumor. Now, you see this image, students. In this image, there is stromal hyperplasia. In both fibroadenoma and Phyllodes tumor, I will see stromal hyperplasia. But students, the image which was shown, it at some places showed leaf-like pattern. And Phyllodes is also called a cystosarcoma phylloides, Why? Because it had a leaf-like pattern. That is why here the answer is going to be a phyllodes tumor, right? The image which was given showed some of the pattern which looked like a leaf. You can see a lot of stromal hyperplasia. Can you people appreciate? The glands are being thinned out, epithelium is being thinned out, and stroma is proliferating, which can be seen in both fibroadenoma and phyllodes tumor. But a lot of leaf-like pattern was seen, so the answer here was phyllodes tumor. Correct? A patient died from myocardial infarction. Following his death, an autopsy was conducted and biopsy was taken from his cardiac tissue. What is the number of days since the injury based on the findings mentioned? This was the image which was given, right? Remember, I told you students the table of morphological changes in the heart after a myocardial infarction is very, very important. Now, what do you see in this image? First of all, let us see. Can you people appreciate that these are the cells which you see in between the cardiac muscle fibers? What are these cells which I see in between the cardiac muscle fibers? These are actually the neutrophils. Now, whenever there is any injury, when do you see neutrophils? I see neutrophils within 1 to 3 days. Remember students, after that, neutrophils are replaced by macrophages, right? So within the first 3 days, I see neutrophils. Because my image is showing a lot of neutrophils, what is going to be the answer? 1 to 3 days, right? Now let us see the options which were mentioned. 3 to 4 days, no. Even in 3 to 4 days, you will have more monocytes. 7 to 10 days, no. What will happen in 7 to 10 days, students? In 7 to 10 days, you will see a lot of blood vessels or granulation tissue, neovascularization. Around 3 to 4 weeks, of course not, because in 3 to 4 weeks, you will see a lot of collagen. So here, you will see blood vessels. Here, you will see a lot of collagen. In 3 to 4 days, you will see more of macrophages. One day, if this was the option which was given, then this is the answer, students. 1 day. That is the best option in this case. Understood? Remember, I told you this is a very, very important topic and all these images can be asked, right? So, we can easily solve this question based upon this concept, right? Then students, next question. A 6-month-old child presented with leukocoria, cat's eye reflex in the right eye. Whenever I am given this history leukocoria, you must have read in ophthalmology also. I start thinking in terms of one diagnosis, students, that is retinoblastoma. Even if I don't have any other history, I will start thinking of retinoblastoma. Let us see the other points. A cranial pathology was detected and the lesion is positive for synaptophysin, chromogranin, NSE, and shows a palisade in a spoke and wheel arrangement surrounding a central core. There is a central core and there is a spoke and wheel arrangement kind of a thing. Identify the condition. What is the condition, students? Is it a medulloblastoma? No. Medulloblastoma is not going to show you leukocoria. Is it a retinoblastoma? Yes, definitely. Is it a pineoblastoma? No, because again no leukocoria. Is it a epidermoid cancer? No. So the answer here is a retinoblastoma. Now, few things about these blastemal tumor, students, because they are asked every year, right? On microscopy, all these retinoblastoma and all, they show what is called as rosettes. Here, can you people appreciate? This is the central core and the cells are arranged like this. This is what they are mentioning as spoke and wheel arrangement. What is this, students? These are called as the rosettes which are there. And retinoblastoma is an example of a small round blue cell tumor of childhood. One of the most favorite topic for INI CET and NEET examiner. What do these tumors show? Small round blue cells. Along with these lesions, students, these are called as the rosette because they look like a rose or a flower. Understood? Can you tell me what are the examples of these lesions? All the blastemal tumors, they are small round blue cells. For example, neuroblastoma, retinoblastoma, hepatomedulo, and nephroblastoma. Along with rhabdomyosarcoma, today only we read Ewing sarcoma on PNET is also a small round blue cell tumor, and certain lymphomas can be there. A very, very important and high yield topic. Again, a repeat topic which was there, right? Next. A patient presented with arm span more than height, that means arms are longer than the height, subluxated lens and pigeon chest appearance. Okay, again students, genetics and clinical correlation. Whenever you hear about lens subluxation and a patient with tall, long arms and pigeon chest appearance, what is the diagnosis which you think of? Remember I told you Michael Phelps, Abraham Lincoln. Which disorder did these people have? Marfan syndrome, tall stature, hyperextensible joints, long extremities, upward and outward dislocation of lens, right? Pigeon chest appearance. So my diagnosis is going to be Marfan syndrome. What is the protein involved in this condition? Marfan, fibrillin. So what is the defect, students? The answer is going to be fibrillin. Remember? Easy? This was an easy question, students. Three kinds of defects are seen here: skeletal defects, ocular defects, and cardiovascular defects. In skeletal defects, you have tall stature, long extremities, hyperextensible joints. In ocular, you have dislocation of lens. And in cardiovascular defects, we have mitral valve prolapse or aortic dissection. Understood? What is the most common cause of death in a patient of Marfan syndrome? The answer is going to be cardiovascular defects like aortic dissection. Understood? Now, this is the history of Marfan's. Brief about Marfan, students. There is abnormal fibrillin function. It is an autosomal dominant condition. Abraham Lincoln had it. The patient has got long bones, high arched palate, dolichocephalic head, pectus excavatum, that is pigeon chest, upward lens dislocation, long spidery finger and toes, aortic dissection, mitral valve prolapse. Life expectancy is halved due to cardiovascular manifestations. Fairly easy question and a common repeat topic which was asked, that is Marfan syndrome, right? Next. Which among the following statement is true regarding PNH, paroxysmal nocturnal hemoglobinuria? You have to tell a true statement, right? Sucrose lysis test is diagnostic. Is sucrose lysis test diagnostic? No. Remember I told you the diagnostic test is flow cytometric evaluation of membrane proteins like CD55 and CD59, not sucrose lysis test. This is wrong. Flow cytometry is gold standard for diagnosis. This is true. It is an inherited condition. No. Remember I told you PNH is the only acquired intracorpuscular defect, right? It's not an inherited condition. Anemia with heart failure is the most common cause of mortality. No. What is the most common cause of death in a patient of PNH? The answer is going to be thrombosis. Thrombosis, maybe Budd-Chiari syndrome, is the most common cause of death, not anemia with heart failure. Understood? So what is the answer for this question? Flow cytometry is the gold standard for diagnosis. This statement is true. All the other statements are false, right? Can you do this question by just ratification? No. You can only do such questions by continuously revising your concepts, right? Few things about PNH, students. In PNH, my patient has got pancytopenia with hypercellular marrow. The patient has thrombosis and intravascular hemoglobinuria. Three very important things. Then few other things. It is the only acquired intracorpuscular defect. There is a mutation of which gene? PIGA gene. What is the full form of PIGA? Phosphatidyl inositol glycan A. There is reduced synthesis of two proteins, CD55, that is DAF, and CD59, that is Mirl. There is nocturnal hemoglobinuria and thrombosis. Pancytopenia can also be there. Ham's test can be positive. Best test is flow cytometry. What is the most common cause of death in this condition? That is thrombosis. Understood? This is the gist about PNH which all of you need to know, right? Next, a child presented with failure to thrive and recurrent infections. On examination, tonsils are absent. Further evaluation confirms a deficiency of ADA, adenosine deaminase deficiency. Now, when you read that my patient has got a adenosine deaminase deficiency, remember in immunity I told you that which disorder has got ADA deficiency? The answer is going to be SCID, subacute combined immunodeficiency. So here the answer is going to be subacute combined immunodeficiency. Very direct question, right? Next, a middle-aged man came with complaints of dyspnea, chest tightness and dry cough. On imaging, he has interstitial fibrosis. Biopsy is shown. Which of the following industry has he been likely working in for the last 20 years? Which industry? When the image is here. Again, students, such a repeat image and such a repeat topic. What is this topic? Asbestosis. What is this image, students? What is this image which you see here? Don't you think this looks like a ferruginous body or a asbestos body? This is actually a ferruginous or a asbestos body. They are basically dumbbell-shaped beaded rod-like structure. My patient was working in a asbestos industry. Why is this brownish color? Because they are asbestos fibers coated with iron. Iron or hemosiderin on histopathology will show a brown color, right? So, this is again a very, very repeat image and repeat topic, right? A few things about asbestosis, students, because this is a very, very common topic. Sometimes you can be given a history of a person working in a construction industry or a shipping industry is very common. Usually it affects the lower lobes, while all the other pneumoconiosis usually affects the upper lobes of the lung. There are two types of asbestos fibers which are there, serpentine and amphibole. Which fibers are more pathogenic or carcinogenic? The answer is going to be amphibole. The most common or the earliest lesion by asbestosis is a pleural plaque. Can you people appreciate a plaque-like structure here? And what is the most common type of malignancy? That is a lung cancer. But what is the most specific malignancy cause? That is a malignant mesothelioma, right? The image which they commonly give, this image, students, these are beaded rod-like structures and these are asbestos or ferruginous bodies. Because they are coated with iron, that is why when you do a pearl stain, what you will see, they are Prussian blue positive. They are Prussian blue positive, right? If I ask you, what is the tumor marker for malignant mesothelioma? The answer is going to be calretinin. And this malignant mesothelioma sometimes can also show the presence of Samoma body. Understood? Let's move to the next question. Which method is more effective than measuring clotting factors for assessing the intrinsic pathway? What is the test for intrinsic pathway of coagulation, students? Very easy question. The answer is going to be APTT. That is the test for intrinsic pathway of coagulation. Correct? Next, an adult male presented with protruding abdomen, diarrhea, visual symptoms and neurological manifestation. Based on the peripheral smear finding, what is the likely diagnosis? A-beta lipoproteinemia, EDTA changes, uremia or burns, right? Now, my patient has got protruding abdomen. The patient has got diarrhea, visual and neurological symptoms. So, a lot of symptoms are there. What do you see on this peripheral smear? First of all, tell me. A burns patient will show spherocyte. Remember? Can you see any spherocyte here? I cannot see. How does a spherocyte look like? A small, totally spherical cell with no central pallor. Can you see? I cannot see. So, this is not the answer. What will a patient of uremia show? Uremia means renal failure, and a patient of leukemia or renal failure is going to show you Burr cells, right? Can you see Burr cells here? I cannot see. EDTA changes? No. A beta lipoproteinemia. This is the answer, students, because when I see this image, can you see these RBCs? Don't think these RBCs have got these pointed ends. They are not blunt ends. They are pointed ends. So this is basically A beta lipoproteinemia, in which we see acanthocytes. These cells are called as acanthocytes and they are seen in A beta lipoproteinemia. Few students also told me that in this question, triglycerides increased was also given. So if it was given that the patient's triglycerides increased, then that is also a clue for A beta lipoproteinemia, and then the answer is going to be this. Understood, students? Then in this image, I have just shown you that how do you differentiate between acanthocytes and Burr cells. Acanthocytes have pokey projections. You can see here, pointed ends, whereas Burr cells have got these blunt ends, blunt projections. Burr cells seen in uremia and acanthocytes seen in A beta lipoproteinemia. Then students, the last question which was asked. A middle-aged man comes with complaints of painless progressive enlarging lesion on his scalp and perianal lesion for the past 3 months. He has had liver and kidney transplant 2 years back and is on mycophenolate, tacrolimus and prednisolone for his immunosuppression. Which of the following is the most likely diagnosis? Is it pyoderma gangrenosum? Do you see any pus? Why will pyoderma gangrenosum develop in this patient, right? And here I am not seeing any neutrophils, nothing related to pus or an abscess. So pyoderma gangrenosum is not the answer. Is it cutaneous TB? I am not seeing any granulomas, something like that. Not TB. Is it any drug-induced eruption? Not really. Because drug-induced will show eosinophils. Is it malakoplakia? Yes, students. This is malakoplakia, in which, in this image, can you people appreciate this dot-like center thing? This is actually Michaelis-Guttman bodies. Michaelis-Guttman bodies. Remember, I told you Michaelis-Guttman bodies are seen in malakoplakia. Now, this was a bouncer question, students. Why? Because till now, we have done malakoplakia in the urinary bladder. I always told you around that. The causative factor can be E. coli, right? We have not discussed about any malakoplakia which can develop on the skin. Here, the examiner gave you the malakoplakia of skin, which we were not anticipating. So, if you ask me, this was a question which was like a bouncer. The answer here was malakoplakia. I could do this question by excluding also, right? With the students, we end the pathology questions which were asked in the session 1 and session 2 in the NEET-PG exam, right? As you all can see, the topics were really repeated but not the direct question, and you could not solve this paper unless and until you have a hang of a lot of images, unless and until you have revised your subject at least thrice and you are thorough with your concepts. Just revising the one-liners, you could not do this kind of a paper. So at the end, I would just like to say that push yourself because no one else is going to do it for you, right? Ultimately, it is you who have to continuously motivate yourself, feel confident and keep revising your subject. No one else is going to do it for you, right? Thank you so much, everyone. Happy studying and keep revising your concept. Thank you.